was quite exciting to see the group work, at least here where I'm present. The online group work that I didn't see, but I believe that it was as good as the one we had here. I must thank the HRC for this opportunity that we've had to sit as a team, as a Northern Cape team, to engage particularly on the outcomes of this study, but also taking it together with what we know to be the situation in our province. The teams that I sat with, I could hear from them even a way forward for us to say what are the things that we need to do. So now it's time for us to share that information together so that we can put together a coherent, complete report on what our thinkings are on this study and what it is that we are learning from it, and perhaps what are the things that we need to consider going forward. We've had 3 teams working here. I will start with those in the house, not to neglect those online. I know when you're online, you tend to be kind of put to the last, but I will first take one team from inside here. The team online will be the second, and then another team inside will be the third one. So we will do those discussions. You will have 10 minutes most for you to present. If you can cut it shorter than that, thank you very much. But you have 10 minutes to present, then we will discuss it briefly, see our understanding of it, and perhaps have some more inputs to enrich what you are presenting. And then once we're done with that, once all 3 groups have presented, we will then again have a question to discuss. I think we will take question 3. That's the one that wasn't addressed in the group. So we will discuss that as the 4 teams, so meaning as the whole house, inside house as well as outside house. So let us start with the group. Which question did the team online do? Question 4. So let us start with question 1, please. Who is the presenter for team 1? It's the Honorable Mr. Liburu. Yeah. There's Mr. Liburu from the Department of Health going to give us the discussions that were made in Group 1. They looked at the shifting patterns of HIV and an aging epidemic. There you are.
Okay, thank you, ma'am. So in terms of Group 1, good morning, colleagues. Oh, is it afternoon? Yeah, good afternoon, colleagues. Yeah, I've got 10 minutes. Okay. So in terms of Group 1, we were looking at answering. The first question was the shifting patterns of HIV and the aging epidemic in terms of what the implications are. So we have said that we need to have targeted interventions to scale up on HIV case finding and treatment initiation, targeting our adolescents. So we need to scale up on our adolescent and youth-friendly services, and to focus also on getting our males on treatment. Then secondly was to put interventions in place to retain and sustain the aging population. You have seen with the data being presented here that there's an aging population, so we need to have interventions in place to ensure that we retain them in care and we sustain them on lifelong antiretroviral treatment. Thirdly, it means that we also, like I've indicated, we need to scale up on HIV testing and treatment initiation for the males, considering the shifting epidemic, the shifting patterns of HIV. Secondly, in terms of where does learning for HIV takes place, we have indicated that at health facilities, at school level also, also at a community level through our community healthcare workers in the community. The best practices and lessons learned, we have highlighted one of the private-public partnership with the mines and the farms in the province, where we've got a memorandum of understanding where clients who are not on medical aid are actually accessing TB and HIV treatment at the mines and in the farms. Then the integration of health services with primary health care. We also have the decentralization of treatment to increase coverage. Fourthly, we have the nerve center approach where we are identifying the underperforming indicators. So we have 2 districts which are implementing the nerve center approach, prioritizing the underperforming indicators, which is ZFM and JTG. Also, the provincial nerve center that we have, where the district nerve centers are reporting to. So we have also highlighted that one of the lessons learned is that we need to scale up on more advocacy, communication on HIV prevention, combination strategies using the different channels of communication. HIV strategies for men, have they been successful? We have highlighted that partially so. We have seen through our performance in the province that we reach the targets for condom distribution, but on the flip side of it, we see an increase in STIs also, considering what was also being presented here, where there's a decrease in condom usage. Then we have the partner collaboration, which seeks to target men, which is Coach Impilo, which is being implemented in ZFM and in JTG. So with the strategy is we have men who are on treatment reaching out to men to test, and those who are testing positive to get them on treatment, and those who have actually disengaged from care to get them back to treatment also. Also, considering the fact that we have said that the strategies for men are partially successful, is what we are considering also the institutionalization of VMMC, seeing that we have 2 RT35 service providers in the province, and we still need to scale up on the institutionalization of VMMC to ensure that our facilities do actually provide this service within our health facilities. Thank you, Chair.
Thank you very much, Mr. Liburu. I think your team really did a great work. You know, when I started and said we were working so hard, and it was so nice to engage together on these questions, I forgot to say, you know, in life, you work, you do everything, you never thank yourself. You are forever a slave. Come on, let's thank ourselves. We did such a great work. We should have done that earlier. We've worked very hard. Just as a thank you very much, Team 1, for taking on board all these questions for us. I just didn't hear, I don't know if it was at a time when my mind wasn't engaged, I didn't hear you speaking to the implications of a shifting pattern of HIV. I've heard you speak about the interventions for it. I don't know if the team has had those, then we can just move on, because I know we will get it in the minutes later. But if you didn't define that, if you didn't tell us what those implications are, and particularly because I think what this study has brought out for us is that ours is an unstable epidemic at this stage. So I think it's important that we address directly that which comes out of the study for us. So can I just put that to you before I open up to the room inside and room outside? Some of you guys are under the covers at home. Do answer, even when you are there. We wish we were there too, because it's cold. So can I just hear, did you address the implications of a shifting pattern of HIV?
Yes, ma'am. I think we have attempted to answer that question in terms of the need to have targeted interventions, because the epidemic is now shifting from the older to the younger. So we need to have our adolescent and youth-friendly services in place, and also to make sure that we target our males.
Thank you. Definitions are very important. It's important for everybody to know what we mean by what, so that we're able to deal with it. If we don't know what we're talking about, then it means we don't know what we are looking at. Therefore, what we don't know, we cannot deal with. So thank you very much, Mr. Liburu. So I'll open up for questions now. Let us start with the team at home, at work, at other places. Do we have any questions online? It's 1 million people online. No questions online. Team online, while we await for your inputs, let me just get some in the house. Any questions, inputs? This is ours, folks, particularly us here in the province. Let us give it our shot. The team that was not part of Team 1. All right, the teams are quiet for now. I'm sure they are still thinking. Let us move then to Team 2, which is the team online. I do not know who the presenter is there. Yeah, you take your nice computer. Team 3, Team 4, successes and challenges in reaching the youth, women, and other populations. Who is the presenter online? We are sitting with serious academics here. There hasn't been a single song or a single anything. People are engaging with their computers and so on. I come from another world, but it is okay. Team online, please let us hear you. Team online, you seem to be speaking there, but you haven't unmuted. Please unmute so that we hear you. Pumzile. Pumzile, are you online? All right, team online, while you are preparing yourselves then, we will have the technical people reach out to you so that you identify to us who will be representing you. So while we do that, let us move on to Team 2. You addressed question 2, which is what HIV messaging is critical to communicate and to whom. Can we have your presenter come up, please? Make it warm and hot. You see now there's no singing in the meantime. It's a pity I can't sing. If I could, yes. We'd be hot in here, we wouldn't be cold. She's coming, team online, hang in there. It's just that the room is so big. There, we put her on a scooter, she's here now. Please go ahead.
Thank you, Chair. Afternoon, colleagues. We did question 2. I just need the question here. The question for question 2 is what HIV messaging is critical to communicate and to whom? How do we reach and empower adolescent girls and young women? Where should we focus and how? And B, how do good role models in young groupings influence behavior? And C, has UEQUEST to you been successful in the province? What could be done to further UEQUEST to you campaigns? Okay. When we were answering our questions, we just we didn't go according to the numbering on the question. So I need help. And the critical messaging, make them more aware of the young people, make them more aware of their physique, especially regarding bodily changes, and teach them prevention methods. For those who've already started engaging in sexual activities, they need to be encouraged to take up healthcare services and circumcision for boys, and condom use. And then foster a close working relationship with schools, DOH, and DOE. Messaging on drug use, especially once they reach tertiary, which may result in sexual behavior. Using influencers to teach influence on delaying risky behaviors. There should be a variety of role models at community level, influencers, famous people, community programs, peer educators, and at community level as well. We also thought of there should be youth zones at facility level. These need to be strongly promoted, because we know that we still have school-going young ones, especially the 15 and above. As a province, we should look into the M&E processes, because we feel that our data needs to be cleaned up and make sure that we have the correct data at all levels. And then districts should be, where we look at the districts that needs more attention, like JTG and Bixley Kasema, which will be to provide more useful data on HIV prevalence than Francis Bart, which is an urban district, because these two districts are more rural. Found the STI prevalence rates were higher in the rural areas of the previously mentioned districts. And empowering young women, increasing activities where we reach out to young women, e.g. some may come from strict households and come to uni and gain independence, so we need to make sure that we support them and give them more information. And then when it comes to the U equals to U launch, the province has launched in August, but we're still working on making sure that the districts also are launching in each district. So we know that they've worked on their plans, so we need to make sure that they launch as well. So far, messaging has been generalized on all sexes. However, the initial messaging was confusing and difficult to understand when it comes to the communication at our local radio stations. So with national, that has actually withdrew some of the messaging. So we need to work on that as well for the U equals to U. Set to use adverts, murals, and billboards to promote U equals to U messaging. We also feel that we should employ a multi-sectoral approach, include other stakeholders for the U equals to messaging. Also have partnered with the mines to launch, so they will be launching soon the U equals to in the mines, I think in November if I'm not mistaken. Also have agreements with other sectors like your farmers to penetrate the messaging of condom use and HIV prevention testing. And then on the VMMC, There are men NGOs programs and forums that are male-centered. These were small-scale civil society-led programs, though they have been halted a bit since COVID-19. Currently, we work with service providers regarding the messaging of the VMMC in the Northern Cape. So far, haven't succeeded in reaching more people there and the targets that have been given. And being dependent on the service providers because to the performance of the programs is seasonal. So the uptake of the VMMC programs is necessary. Okay. Oh, I think we've covered everything. Yeah, I think I'm done. Thank you.
Thank you very much, Team 2. Wow, that was actually quite detailed, the presentation of Team 2. And I think for me, research team, what it tells me is that as a province, we actually do have programs and activities and actions that address these problems that we have here. It is now a matter of saying where to put our focus, where should we put on more emphasis, where should we shift more of the few resources that we have towards in order to ensure that next time this study is done, we have much better results. So we truly appreciate what this team has done, but can I hear if there are any further additions to what they've said and comments perhaps? Much appreciated. Team online, well, I know you are a team, but you are fragmented. Everybody is in their own space. I didn't quite realize that initially when I was speaking, it was like all of you are congregated in one person's bedroom somewhere out there. So you can speak and then give us things. I apologize for that. So individually, if you do have another input, additional input to help us make good work of this, please type it or send it in for us. In the house, any hands? 1, 2. There's one head. Any other at 2? Okay. Please go ahead.
Thank you
Dr.
so
Sillo.
Thank you so very much. My name is Refilwe, Dr. Refilwe Sillo from CDC. I'm the CDC Provincial Engagement Lead. So I'm really grateful for the presentations from the first group and the second group, but notably also from the second group and about the U equals to U. It's very interesting how the province has launched U equals to U in collaboration with the National Department of Health and also SANEXO, but just wanted to commend the province on the launching of U equals to U and the upcoming plans that you have for the districts. And also to note the your innovative collaboration with the mines. You're also going to have, you're planning the U equals to U in the mines. I think that's very commendable. It's a transformational partnership. I think that's a very good progress and something to even share with the rest of the country about how you're collaborating with like private sector and the business community. And also appreciated the different programs that are there. I know there's different issues of cost containment. I think Mr. Leburu also talked to it. But just to see how the Northern Cape leadership and the different multi-sectoral responses really come together to try and see like how they can implement some of these different strategies and from the National Department of Health or from national in general, and you know how to make things work as much as possible. So wanted just to commend the province on that, on what great leadership you've had, and obviously through the head of secretariat leadership also. Thank you.
let us, team online, well, you are no more a team now, you are participants online, or online participants. Online participants, thank you very much for your inputs. We've received your inputs and it will be presented from this side. Thank you. Hold on. Yeah, Ms. Tembelihle is going to be presenting your inputs for us. Thank you.
Thank you, colleagues. I'll be just sharing the points that were discussed by the online team, which focused on question 4, success and challenges in reaching youth, women and other populations. A was, how do we So the team online said the province use of other services. The use of female condom, and educating parents on sexual reproductive health, because that's where children get their information from. Integrate sexual reproductive health programs that are already taking place in schools in the curriculum of life orientation. They further said that champions and campaigns that are youth-friendly, like your peer-to-peer education, needs to be empowered, and people that are dealing with safe sex practice need to be empowered and encouraged to further strengthen their programs. And then B was, how do we better coordinate efforts on health interventions, strategies at local levels in South Africa? The points that came were multi-sectoral approach when dealing with sexual reproductive health and behavioral factors, have the client as the center of these interventions. They said they need to strengthen the existing collaboration among different stakeholders. They said that they need civil societies in all communities and to make the use of civil societies when initiating programs to better coordinate at community level. They further said that all departments need to be able to inform each other on existing programs so that they can further integrate with each other. They said there's a need of assistance from governmental organizations. The youth needs to gather or be provided with data so that they can be able to reach or online platforms in terms of sexual reproductive health. They said that there's a struggle to interlink as a province. Therefore, there's a need for advocacy of services available at school health, and that there's a need for synergy between SGPs and clinical communities, and that they're saying that the experience in healthcare seeking is more hostile and it requires a more relaxed approach and it needs to be youth-friendly. And then C looked at how is HIV testing and awareness, art and viral suppression seen in the community of Northern Cape. They said that stigma is still present and that prevents people from testing. Small communities and the healthcare workers knows the patients, therefore people are reluctant to go to clinics for testing. And they say that male testing is low because of stigma and that there is limited male-friendly services in the province. And they further said that there's a shortage of testing kits in the province or on the localities where they are based, and that the Department of Sports that has access to males and this youth need to be utilized to help and reach males and youth in terms of health services that they need. And then they say that there's no training provided to health workers in terms of such, so they need to train health workers in the province. And then they further said that self-testing kits are more desirable at the communities and more people are willing to participate, and a more regulated form of self-testing is needed. And then they said providing self-testing at the communities using outreach team programs, which is more working. They've seen that it is, the outreach team programs are working, so they need to strengthen and intensify such programs. And then they said HIV vending machines in TVET colleges for the youth need to be adopted, and that those that already have them, they need to strengthen such strategies so that the youth can be able to access these HIV testing kits. Then they said that testing kits must be more regulated and efforts must be concentrated on them, because they see that when people are given their own testing kits, they turn to test more compared to them having to access these services at the facilities. Thank you so much.
Hi, in-house team, let us give the online team even more of a hand. They've truly engaged with their question. It's amazing to see how much input came from out there. Thank you very much, team. Next time I have to host something like this, I will definitely say everybody must go online so that we get this quality kind of engagement. You've really given us very, very good. Highly appreciated. We will make work of the inputs that you've given. Anyone in-house wanting to add a bit or to just make a comment on the inputs of our online participants? One. It worked last time. Once I started counting, there was a hand. 1, 2, 3. They say uqhela magwala. Online, is there any hand, please? No, there is none. Thank you very much, team, for the work that we've done. Now, we were 3 teams only, but we had 4 questions. One more question remains, and I want to pose it from here, and let us get inputs from you from the table here, and from you guys online. Please type in your inputs on this one. This is question 3. It reads, what needs further strengthening in the province or district program? What needs further strengthening in the province or district program? Yes, provincial program needs strengthening, but as we all know, we are now moving towards district implementation under the MDIPS. So I will appreciate hearing more on what it is that we need to strengthen at district level, because what is done at district in any case filters up to the provincial level. So let me start with question A. There are only 3 questions there, but please feel free to elaborate, because that's what will help us in moving on. Question A is, what has been the result of voluntary medical male circumcision program? What's been the results of the VMMC program? Do you know it from your community? Have you seen some of it perhaps from the study here? What has been the result of the VMMC program? Question posed to you. Let's have some hands in-house and online. Team online, we are monitoring. Should your hand come up, we will definitely give over to you. Any hands in the house? Question A, what has been the influence? Am I reading the right one? What has been the result of VMMC programs? Or is the question not clear enough? Are we seeing a result? Are we seeing any changes as a result of the VMMC program that we have? Does it have any lackings that we think could be improved in it, and so on? Yes, you may answer.
Thank you, Madam. My name is Tebogo Olifant, currently coordinating the MMC program in the province. What I can say is that we really need strengthening in terms of the VMMC program. As it is that currently we are dependent on the RT tender, of which we're having 2 service providers, one servicing JTG and Francis Bart, and the other, which is Lister Health, servicing Pixley Kaseme, Namakwa, and ZFM. So studies have shown that yes, MMC does have an impact, and it really contributed towards the reduction of HIV incidences. But what one can say is that we need to advocate more into condom usage as part of the integrated activities within the MMC, because when creating the demand, it should be clear that condoms, we are not cutting them off. We're still saying usage of condom is important. Thank you.
Thank you very much. But while you're still standing, maybe you can just take this one as a clarification from you. In the MMC program, particularly the provincial aspect of it, can you just give us a breakdown of whether it is is male medical, the medical aspect of it, how acceptable is it in the province? How many people go for it as opposed to traditional male circumcision? And what, in your opinion, are the things that we can do to make an improvement on both? Because traditional circumcision is also fine, but we do know that there are some challenges going with that. Perhaps as a practitioner in that field, you can just give us some advice. How do we improve VMMC in terms of traditional circumcision and the medical circumcision? Thank you.
Okay, thank you, ma'am. I will be talking on the side of MMC. For now, in the province, the traditional circumcision has been left to its custodian, which is Cogstar. So they are running with the program. But MMC is acceptable in our communities. The issue that we are currently just having is increasing service access points. We do have the demand is there, but now we do not have increased service access points since we are depending on the service providers as indicated earlier. So with that being so, MMC is dealt with as a seasonal service, of which we are trying to redirect our service providers to say that we do not have to treat it as a seasonal. MMC has to be a continuous service throughout the year. And in so doing, we are also trying to institutionalize MMC, of which we're having about 3 facilities that are having MMC on a regular basis, even though it's weekly, once a day in a week. And I can say that we are seeing quite a bit of change. We are seeing the immediate priority attending or going, seeking for MMC, which is now your 15 and above. And then during the seasons, your June holidays, we see quite a lot of MMCs done in the province. JTG was the one that actually surpassed its target for Quota 1.
Okay.
They surpassed their target for Quota 1, but if you look deeper into it, you'll see that mostly it's your 10 to 14, of which is not really our priority, the immediate priority that we are looking for. So what one can say is that we should further try and create demand, especially in institutions of higher learning and also in the out of school men out there. Thank you.
We have one more hand in the house, Dr.
Thank you. Yeah, just to follow on those comments and your question, Ms. Paula, about demand. Say it was not presented in the slides, but in the report, the survey does capture information about demand for VMMC among uncircumcised men. So that's something that you could look forward to in the report as well, and may provide some additional data to the question of demand. Thanks.
Thank you very much for those inputs. Let me quickly read one input online. It comes from Dr. Fatima Malo. Dr. Fatima Malo is the leader of the research sector in civil society. She writes, we need to ensure and have M&E follow up on people living with HIV, members who attend these trainings, because we find that the information is not shared accordingly. Most members attend training for personal gain and do not for the community at large. Recommendation for Department of Health to also invite service providers and stakeholders to be part of the new development trainings. And in that manner, the PCA, M&E can have traceable records and a paper trail of the work done on the ground. Thank you very much, Dr. Malo, received. Any other inputs? All right, let us quickly then, some people might be hungry now, but let us quickly move on to question B. Question B is, have youth HIV prevention campaigns been successful at reaching its target audiences? Talk about youth HIV prevention campaigns. How successful have they been at reaching the target audiences? There's the question. Online folks, please don't stay behind. Keep on giving it to us. We are keeping our eye on what is written. Any takers in the house? The youth HIV prevention campaigns, how successful have they been? Or what is your view of them? How do you see them going? Do you think they will work in the format that they are now or not? No takers in the house for that question. Youth HIV programs, we do have quite a few. Recently, 2-3 weeks ago, we launched the Provincial Youth Prevention Strategy at JTG, the place that we've mentioned earlier on, to would have been our preferred place for this study to be done. I think they have a great potential. We have not yet measured, Dr. Kangelani, the impact of that, because yes, we've had activities before, we've had programs running before, even before we put together the strategy, they were running programs. So it's something that we will monitor as we go forward now. But in line with the outcomes of this study, we will be looking even in that prevention strategy to see where to put on the emphasis really, not to just look at the blanket, the whole blanket of the thing. So I think this question, I think everybody online and those in here that are not responding to this, it's because we haven't yet measured directly the impact of those, because they're just starting. So in maybe 18 months going on, we should be able to at least produce some information or data on how those youth programs are going. The final question, have HIV prevention strategies for men been successful? What are the best practices to focus on? Prevention for men, HIV prevention for men, how has it been? Let's talk about it in our province. We've seen the data that's come out from the study, so let us try to see for ourselves. We can interpret what's there, but also what we know. So HIV prevention for men, how has it been? Any takers in the house? Any takers online? All right, there is one taker in the house from Pixlika, or Mr. Liburu.
Okay, Itumeleng Liburu. Thank you, ma'am. I think the fact that we have noted that in terms of the genders, we have less men who are actually testing for HIV also becomes then key in terms of how then do they access these combination prevention strategies. We have seen that the condom uptake is decreasing, and also when we look into our data, we see that there's an increase on your MUIS, your MUS, your male urethritis syndrome. It actually gives us an indication that we are actually having a challenge in terms of males accessing or utilizing the prevention services.
Thank you, Mr. Liburu. Any other comments? You know, we really have to look at our male programs, and not just the program itself, but how we present it to the male person. Because it's not what you tell me, but what I hear you saying. And what I hear you saying doesn't only comprise of the words from your mouth, but also from your body language and from everything else. So we need to give a better emphasis, or better, I don't know, we must find a better way of how we engage males. We do see, if we look at our HIV program, because it is the information at the end of the day, it's the data that tells us where we are at. We're not taking word of mouth from anybody. The data shows us that young girls are highly infected in the province. And we look at their age and we see that the boys that perhaps should be the ones causing the infection are in fact not as infected as these young girls, which then tells us that it is the older men or older young men that are continuing to have relations with children. We've seen also the pregnancy rate in the province, the school pregnancy rate, how young children, we do have an 8-year-old that has gotten pregnant in this province. She didn't sleep with an 8-year-old boy, obviously. So those are the things that we are seeing that tells us that our male prevention program is not working as it should. I'm not saying it will be working if men put on a condom to go and rape an 8-year-old. It will still not be working. In this province, as it is in the whole country, we do have a very high GBVF rate. Those are the things that tell us that because women are not only physically assaulted, girls and young girls are not only physically assaulted, but also sexually. So we do have a problem in that. I submit without any data to say that our male prevention program is not working as it should. We need to look at ways to say, how are we going to improve that? How are we going to speak to the men? Where are the men we need to speak to? Who is better placed to speak to them? I've always said that HIV prevention is a very serious business. If in this room, any of you ask me whether I had sex last night, whether I had it or not, I will say no. You ask me, did I use a condom? I will say definitely, knowing very well that I didn't use it. When I travel out to go to places, when you ask me, do I have a small house here or there, everybody will say no, and yet indeed they have it. Why? We are speaking to people as a collective. We are speaking over people's heads. We've heard the issue that relates to the stigma. We've heard from, was it Group 1 or 2, that brought out the issues of stigma related to HIV and AIDS. We need to find a better way to engage people. And I believe that a person-to-person approach is the best. Where you speak to me in my house, in my environment where I'm comfortable with things that directly relate to me, not to come and tell me about, well, if I'm one of the LGBTQI, you come and tell me, oh, you know the men, they say I'm lesbian. The men in this community are doing all this. It means nothing to me. Speak to me about who I am within the factors that are around me. Then I will hear better. So we need to look at how we improve those things. Our male prevention program is not working as it should. That's why the burden of HIV still continues to be heavier on females rather than on men. So at that point, I want to thank you all for the inputs that you've made. And to the team online, thank you for staying alive to this. Can I now hand over to my this thing beats me, but I want to say the here with me to take over the next part. Doctor. Oh. All right, I got tired too quickly. That's because you guys sitting here don't pay me. Nobody even offered me coffee in this time that I'm standing here. So I do have a further responsibility, which I almost abdicated on. Miss Sheila Lute, are you there? Beloved. Please, I want to...
Let's see a tip. Good afternoon, I'm online.
You are online. Okay. Will you please then give us the reflections on this presentation, this wonderful presentation that we had today, that puts our province, that gives us a mirror view into where we are in the province and also what it is we need to do. Up to you, Ms. Katz, Lute.
Good afternoon, colleagues. Good afternoon, everybody. Just a disclaimer, I forwarded the presentation to Mr. Tembani and Mr. Liburu. I've got the limitation of sharing this reflection on this platform. So if anybody can assist to share the presentation on this platform, I will appreciate it.
Thank you, Sheila. That is being done. Please wait a moment. You'll see it shortly. Thank you.
While they are sorting out the presentation, perhaps you can just speak to it and then it can be shared with the colleagues. I'm just worried about the time.
Okay, let me try to do that.
Okay, it is now shared online. I hope you can see it.
This is not mine.
Okay, if it's not, then we can just remove that and then you can just speak to the points that you wanted to reflect on. Thanks.
Okay, thank you. Colleagues, good afternoon once again. And I almost said special welcome, but we appreciate the feedback from HSRC. You know, it almost felt, not almost, it felt like being in a peer review where you are being asked, informed about your performance, and then you have been asked, where can we assist you? What do you think are the issues that make you to perform the way you are performing? So indeed, for me, it felt like a performance review. In fact, on every month, every quarter, when we review our performance, this is a feeling that I get. So we do appreciate this research findings. We also appreciate all the work that went into this survey. We appreciate all the field workers that went out there and the respondents that responded to this survey, so that we can get an idea as to what is the prevalence of HIV and the behavior related to the HIV in the Northern Cape. Colleagues, we know Northern Cape is the largest province, sparsely populated, so that comes with its own problems. But as we soldier on in the fight against HIV, we've made strides over the years. So I would also acknowledge the reflections on the progress made over the 30 years. HSRC mentioned 20 years, but we've been almost more than 30 years in the HIV epidemic. All the frontline workers, academics, non-governmental and community-based organizations, researchers, political leaders, religious leaders and healers, and policymakers. We acknowledge all the work over the more than 30 years in the HIV epidemic. Surely we made strides. However, we acknowledge that there is further room for improvement. We also acknowledge the findings and the trends of the survey. And of course, we can see the similarities also in the current data. In the past, the survey, the HIV prevalence survey, focused mostly on the prevalence. And we are pleased to see that the survey expanded beyond the prevalence, including social behavior, including our children and other vulnerable populations. The survey also shows that the health services are more curative or more aligned to treatment than preventative. If you remember the slides on our performance with the ARV program, that we're performing well on starting people on ARVs. However, our prevention programs needs further strengthening. I've put a question mark alongside sexual assault. I might have missed the discussions on sexual assault and PEP and psychosocial support, but that is also an area which we need to zoom into, because we know that sexual assault also is a risk factor, and the non-administration of PEP is a risk factor for HIV. Further reflections on today's deliberations, we also accept and acknowledge that the prevalence is at 8.9%, and the increase from 2017. We are concerned that the prevalence rate increased by more than 21,000 people living with HIV. We are concerned that children are left behind. There are low testing rates amongst children, low ADSTAT rates amongst children, and low viral load suppressions amongst children. And these children are our future generations. Most of us above 45 will die out. And these are the children that need to be HIV-free, even beyond 2030. The question that we need to ask ourselves is that 2030 is around the corner. Will we have an HIV-free generation by 2030 if our VTP program shows that the HIV prevalence amongst our children also increased slightly? Are we going to meet our 2030 target of HIV-free generation. So we need to give special emphasis on supporting our children, preserving our children, and to ensure that we have an HIV-free generation by the time we have demised. We note that the HIV prevalence amongst 45 years and above is also increasing. It may be due to the ART program that it's working and stabilizing the HIV epidemic. However, we need to give more support to the people, the older people living with HIV. Our focus has been on children and young people, and we've made strides. However, this age group is also left behind. Now, when we talk about intergenerational sex, this is the age group that we need to look at. Young people engaging in sex with older people who are HIV positive. So the messaging and HIV prevention messaging and U equals U needs to go out also to the older generation. That when they engage into multi-partnership sex or intergenerational sex, they need to be cognizant that HIV still needs to be prevented, STIs needs to be prevented, and that U equals to U can reduce our HIV prevalence rates. So, colleagues, let's not leave this age group behind. In terms of gender, literature shows that males have a poor health-seeking behavior. That has been repeated over and over again, and there's a call that we have to focus on men. We are not doing well in this regard. We have to think out of the box. What strategies can we implement to reach our men in terms of health-seeking behavior? So whilst it's noted that more young women, the prevalence is higher in young women, we need to explain this in context that women report, women test, hence you'll find the prevalence being higher than in men. That doesn't mean the prevalence rate is lower in men. We have to explain this in context because it can be misunderstood. Then further to expand on the prevalence amongst key populations, key and vulnerable populations, I might have missed this in the findings. However, in the previous survey, it showed that the Northern Cape has the third highest in terms of HIV prevalence among sex workers, and also an increased STI rates in the Northern Cape. One of the speakers indicated, one of our colleagues, provincial colleagues indicated that our MUS rates in the Northern Cape are extremely high. We need to look at this in relation with our condom distribution rates. Whilst we are performing in terms of condom distribution, we are concerned about condom use because we can see that our STIs are increasing whilst the rate of condom distribution is increasing. This signifies that whilst we are distributing, we are not educating for correct and consistent use of our condoms. Where I'm seated, I'm asking myself, should we measure condom distribution? Should the indicator not be revised? But in contrary, the colleagues feel that we cannot measure condom use. So we will need some technical expertise or technical advice whether it's correct to measure condom distribution, because distribution does not translate into use. It does not impact meaningfully on our STIs and our HIV transmission. Furthermore, colleagues, on the interventions that we have to implement, and a lot of you in the room and online spoke to these interventions that we need to strengthen. Colleagues, look, these interventions are there, but they need to be strengthened. So what we are advocating strongly is that we need an improved resource allocation. Now, when we speak resource allocation, colleagues, we're not speaking conditional grant, no. We're not speaking conditional grant. We are speaking about resource allocation from all sources of funding and not only the conditional grant. You cannot control the HIV epidemic by only using the HIV conditional grant. We need a better resource allocation. We need an equitable resource distribution and utilization of these resources to strengthen the HIV response. And when we speak about improved resource allocation, equitable distribution, a better utilization of these resources, we're not referring to Department of Health. Remember, this is a multi-stakeholder partnership to address this epidemic, to contain the epidemic, to sustain the gains made over the 30 years. It's not a Department of Health issue, but we need all stakeholders, government departments, private sector, business sector, like I said, our non-governmental organizations and other stakeholders to ensure that we contain this epidemic and preserve the gains that we made over the 30 years. Like I also said, advocacy for better partnerships at local and at a national level and the private sector as well. Throughout these discussions, the issues of prevention came out. Colleagues, we acknowledge that HIV prevention in the province is not optimal. We've noted poor MMC uptake, poor condom use, poor uptake of our DEPI ring, poor uptake of our PrEP, and our PrEP, as well as advocacy on delay of sexual debut. So all those combination prevention strategies needs to be strengthened both at the government level and at the community level and at private sector and business sector levels. Hence, all the stakeholders mentioned previously plays a significant role to ensure that we prevent HIV and not have a curative or a treatment approach to HIV, but rather a preventative approach to the HIV epidemic. We also need to have a targeted approach and target men, key populations, children. Now we say when children are not testing, are not on ARVs, who is to be blamed? The primary caregiver or the caregivers of these children are to be blamed, and those are the people that we have to target when it comes to children. We also need to render better psychosocial support to older people living with HIV. Now, most importantly, if we have to strengthen HIV prevention programs and also ensure that our U equals U is effective, we have to scale up social behavior change and communication, and we have to invest in it. Now, when we look at HIV prevention strategies, where do we place social behavior change and communication? How much capital goes to social behavior change and communication? When there's cost containment, this is the first area that is being cut, and which is a big mistake. Because if you don't communicate prevention messages, if you don't communicate treatment messages, how likely is the end user or the healthcare user going to listen to you, going to use your services? It's very unlikely. So we need to advocate for better resource allocation for social behavior change. We have established our TB caucuses, we have our provincial councils on AIDS where all our political leaders are sitting. These are the platforms that we need to advocate for better resources and allocate more resources for social behavior change and communications. If I may have to take you back to COVID, how much money, resources went into the COVID pandemic? We have successfully contained the pandemic. Why? How? Because resources, political will went into COVID-19. So we are more than 30 years in the HIV epidemic. However, the political will, better collaboration with stakeholders, and social behavior communication, we are not investing enough in our SBCC strategy. We have to deal with social determinants of health. In this province, the high unemployment rate is a risk to our HIV program. We are speaking about young people that we need to prevent HIV and sustain the gains that we made for young people. However, the unemployment rate amongst young people is high, and it's a risk for this investment that we've made to contain or to reduce the prevalence amongst young people. We need to address gender-based violence, which also poses a risk for the HIV, the gains that we made in the HIV epidemic. There's good political will, however, it needs to be sustained. Messaging needs to be sustained. Psychosocial support to people who are at risk for gender-based violence needs to be maintained. Not leaving out our LGBTIQ and our sex workers who are also at high risk of gender-based violence. We need to strengthen community-led monitoring, which aims at ensuring better access to health services and stigma reduction. SANAC is spearheading the community-led monitoring. We appreciate. We have to ensure that our frontline workers at our health facilities understand the aim of this community-led monitoring. It is not a policing intervention, but an intervention to assess access to health services so that we can improve on access to health services for our key and vulnerable populations. We need to look at interventions to expand health services beyond health facilities, beyond 8 hours, beyond 24 hours. We need to increase our community-based clinics, especially for our men. In the Northern Cape, we do not have partners that provides services beyond 8 hours or beyond our health facilities. In other provinces, we know that PEPFAR is supporting such interventions, and we would appreciate some support or technical support in how to implement these activities. And of course, it comes with resources, and we need to advocate for those resources. We are rolling out our human rights trainings for our frontline workers, which have a potential to reduce stigma and also increase our access for our healthcare users to our health facilities. So while the funding was for Francis Barrett for the human rights training, we will expand the training to John Taulo Haitziwi district and to the ZFM district. We're also lobbying to train master trainers so that when the Global Fund funding ceases, that we are able to sustain this human rights training beyond the Global Fund funding. I've put a question mark on stigma, the stigma index, because I'm not sure how do we measure stigma. In the 30 years of this, of more than 30 years of this HIV epidemic, colleagues, when we look at the uptake of testing, the uptake of our ARVs, are we saying that we have not made strides with reducing the stigma? We acknowledge stigma is still there, but can we acknowledge that we made strides? Can we have some evidence that we made strides or we haven't made strides? In my view, we have made strides in reducing the stigma. I'm not saying that stigma is not there, but let's acknowledge the gains that we've made over the 34 years of the HIV program. We can do better, we can do much more to further reduce the stigma, but let's acknowledge that we have done a lot to further reduce the stigma. So colleagues, on that note, I can have about 30 slides on what was discussed today, but in summary, those are the reflections. And I would upfront want to thank all the participants, HSRC, and the partners who brought us this information so that we can improve on how we do things, improve on the services that we have to render to our people, to our key and vulnerable populations, which includes our children as well. There might be more reflections. We hope to have all the information gathered today so that we as a collective with AIDS Council and other social sector departments can then further strategize on how to reduce the HIV, the risk for HIV, and sustain our gains that we've made over the 34 years. So on that note, colleagues, thank you very much. I will listen to further deliberations. Thank you.
Thank you so much, Ms. Sheila Nito, the Director for HAST Northern Cape Department of Health. A lot has been said that we need to reflect on and see what we can act on as the province, and also some of it as researchers are able to also perhaps provide further details, especially related to the data that we have. So I'm going to call on Ms. Sheen, Yolandi Sheen, who has led the planning and implementation of the dissemination drive for the HSRC, working closely with the CDC colleagues. We've mentioned that this is the last province that we've disseminated on. We just thought we can just also have a few words relating to dissemination as one of the projects that we are also thankful that PEPA has funded to help us be able to discuss with you colleagues. And afterwards, we will also just display an evaluation form. Are we able to? Okay. Okay. As she prepares, we will ask the colleagues, perhaps after Yolandi has spoken, we can just have the code there.
Thank you very much. Colleagues, it really is a great privilege to have the opportunity for reflection. It's been a journey over the past 2 months in terms of implementation of the dialogues, but actually our dissemination process started in November 2023 when we first launched the summary results for the national results. And that actually led up to activities for World AIDS Day. So a lot of the information that was launched was actually fed into World AIDS Day in 2023. So not only has this been a journey geographically, but also in terms of our team of researchers, our support staff, our partners, our funders, as well as really working very closely with our provinces and all of the relevant stakeholders that have really made these dialogues a success. And of course, without the funding support from PEPFAR via the CDC and also their technical support, we really wouldn't have been able to make this possible. This is the first time that the HSRC has disseminated at a provincial level to all 9 provinces. And it's really been a great honor and privilege to be able to go back to the provinces and really engage with the people that are making a difference and working so hard on the ground. So really it has been a privilege for our research team to be able to work closely with you and to create a space for discussion, for dialogue, and for engagement between all of the very important partners at provincial level. It's very, very important to us that the data that we generate from the survey is used for planning and programming efforts. What next? I think that's the big question. And I think that the one thing that we've spoken about is the fact that we will be sharing provincial reports with colleagues from all provinces. So please expect that in the next few weeks. We're busy finalizing that. And I think, you know, ongoing engagements with you as a stakeholders is very important. And we've been actually doing that now with other provinces as well. After the dialogues, we've been having ongoing engagements. And I think the last thing that I would like to ask is, you know, SABSSM VII will come along very soon before we know it. And I think we really need your support within the province in terms of all of the stakeholders to help us ensure that we get people in the province to participate if they've been selected for the study, so that we're able to provide this level of information back to you. I think one of the other things as well is that what's come across, I think, at every province is really the need for improvement on messaging around SBCC. And I think that's one of the things that's very important to the HSRC as well, that we really utilize this information that we've been able to garner from the dialogues to really see what we can do to help the various provinces. So we will be engaging with you further, and thank you very much for being at this dialogue, for those online as well as in the room. And yeah, we will definitely watch this space. Thank you.
Thank you so much, Ms. Yolandi Sheen. Before I call Mr. Adlai Davis to close the event for us, as mentioned earlier on, would like to evaluate this event so that we come back and do it better and bigger if that is possible. So colleagues, if you can just screenshot, also those who are online, if you can just screenshot the code so that you are able to access 3 questions related to your participation in the dialogue. We would really appreciate that. Colleagues that are closer to you should also help you in terms of how to navigate and access the information. We will be able to get it. If you are not able to do it right now, we ask that you do it as Mr. Adlai Davis will also be just closing for us. So please, colleagues, we would appreciate your participation or feedback to help us to plan for the next dissemination.
Thank you very much. Colleagues, yeah, safe to say, what's left for me to say is to thank all of you who came out on this very chilly Kimberley day, which is incredible because Kimberley, I always had to be looking for cover in summer, but it was great to be here in Kimberley. So thank you for the online participants and those in the room. And I want to extend, as a coordinator for the Northern Cape, in planning this dialogue, my sincerest thanks to Mrs. Satima. Thank you very much for you, for having, and for Ms. Lute, that's Mrs. Lute online. And then a special word of thanks to Mr. Gordon Masaile, who I had to harass sometimes. I'm sure if he felt harassed, because we had to, and he had to do his level best. I remember one of the meetings he had to take on his car on the way to drive to Kimberley or somewhere. And there was always a matter, but thank you for accommodating us. Thank you for getting back to us as soon as possible so we could to have this event in the end. And we're really happy and glad for that we could do it. To our audiovisual team and our media colleagues, ADSI, and not only keeping everyone online engaged, but also making sure that the result get its exposure in the media. We thank you very much for that, so well done to you guys. And our admin colleagues, who's been geographically and all the while just getting us from one place to another relatively seamlessly, but you know, it's a lot of logistical planning on your side. So guys, you did a great job. So thank you very, very much for having you. And momentarily in his absence, Professor Kangalani Zuma, who led the research team, were the face of the research team most often, but also to our colleagues who work behind the scenes, crunching those numbers way into the night, and making sure that what we say and what we share with CDC, and for CDC to also get back to us to make sure that they're happy with what is being presented. So colleagues, to you also, very, very well done to that research team. Just to say, the research work is not done, as mentioned just now. Yolandi mentioned it. We are working on those provincial reports, and these will be shared and circulated towards before the end of the year, so we can go on the Christmas break armed with those provincial reports. And just to highlight, many of the feedbacks we got from the groups now was specific questions about certain modules that we may have not reported in the presentations, but the ones that dealing with, the modules dealing with stigma, the experience of gender-based and other forms of intimate partner violence, psychological distress, the barriers to ARV uptakes, the qualitative work that's been done. And also, we also do smaller, targeted, focused HIV studies amongst certain groups like commercial sex workers, etc. So we do that kind of work, and we hope to also report on them. Then, just as a notice, is also all the survey data that we've been done, all 6 iterations of the survey, is available for download because it's all curated. So for those of the colleagues who have connections, I did extend one invitation to Salt Lake University to come and join us here today. Unfortunately, they're not available. But the point is the data is available for postgraduate studies. So people who are interested in this work can mine the data further and be able to glean even more value from it. So for those who are thinking about postgraduate work in the field of HIV and AIDS, etc., please do contact us because the data is available for use and further analysis. At the risk of sounding repetitive, I must say PEPFAR through CDC has been a wonderful partner in this project, but specifically around the dialogues. And Dr. Joseph at the back there, for you and the rest of the team who's been with us, for encouraging us to have this, for funding us, and for supporting us like you're doing here today, yet again. We must say, please pass on our thanks to you here, and to please pass our thanks and extreme gratitude to the rest of your team at CDC South Africa. So thank you very much. And colleagues, for you who will be traveling, please enjoy your lunch, and please travel back safely, because we would like to have all hands on deck as we go on in this dealing with this epidemic. Colleagues, thank you very, very much.
Lunch is ready for us. Just outside there is a colleague waiting for you just to direct you there. And yeah, travel safe, and thank you so much for those that are connected online. Enjoy your lunch from home as well.